All right, welcome everyone. Today we're jumping into a topic that you are absolutely going to see, whether you're in the clinic or maybe even on your own travels: high altitude illness. So let's get right into it. So picture this. You're in the clinic and a patient walks in with a classic story. They just got back from this amazing ski trip, right? But now they've got a pounding headache, they feel nauseous. So what's on your mind? Could it just be a hangover? Maybe they picked up a bug? Or could it be something directly tied to that trip? This is exactly why you need to have altitude-related illness on your radar.
Okay, so before we can even think about diagnosing this stuff, we've got to understand the why behind it. We need to start with the basics, the pathophysiology. What is actually happening inside the body when you go from sea level up to the top of a mountain?
And it all boils down to this one key concept: hypobaric hypoxia. Now, here's a common misconception. It's not that there's less oxygen in the air. The percentage is pretty much the same, around 21%. The real problem is the barometric pressure drops. The air gets thinner, which means with every single breath, you're just pulling in fewer oxygen molecules. And get this one single thing is the root cause for everything we're about to talk about.
So who do you really need to be on the lookout for? Well, number one, the biggest red flag is if they've had altitude sickness before. If it happened once, it's way more likely to happen again. Another huge one is a rapid ascent. That's just climbing too high way too fast. And then, of course, you've got to think about your patients with underlying lung issues, right? Folks with COPD or pulmonary hypertension. Their bodies are already working overtime to get enough oxygen, even at sea level.
All right, so we've got the why. Now let's look at the what. What does this actually look like in a patient? And that brings us to the most common presentation you're going to see: acute mountain sickness, or AMS for short.
And when I say common, I mean really common. Check out this number. A full 25%, 1 in 4 people who go up to just 2,000 meters are going to feel some effects of AMS. To put that in perspective, that's the altitude of a ton of popular ski resorts. So remember that patient we started with? Yeah, AMS needs to be way, way up on your list of possibilities.
The tricky part is the symptoms are super nonspecific. We're talking headache, fatigue, nausea. It can feel almost exactly like a bad hangover. But one classic sign to look for is really disturbed sleep. This is because of something called high-altitude periodic breathing. Basically, the low oxygen messes with the brain's breathing control center, so people have these little pauses in breathing all night long. But here's the good news. If the person just stops going higher, these symptoms will usually just fade away on their own in a day or two.
Okay, but what happens when it's not just a simple case of AMS? What happens when the body just can't keep up, when its defenses are totally overwhelmed? Well, that's when things get serious. We're now talking about two life-threatening emergencies: HAI and HAP. And it is absolutely critical to tell these two apart, and fast. So, HACE, that's high-altitude cerebral edema, is swelling in the brain. HAP, high-altitude pulmonary edema, is fluid in the lungs. Brain versus lungs. The key sign for HACE? Ataxia. The person literally can't walk a straight line. For HAP, it's severe shortness of breath, even when they're just sitting still. It's pretty incredible, right? The same initial problem, not enough oxygen, can lead to total disaster in two completely different parts of the body. Let's zoom in on HACE for a second. Make no mistake, this is a full-blown neurologic emergency. You can almost think of it as the final, terrible stage of AMS that's been ignored. The patient gets confused, maybe really irritable, and then they start stumbling around with that classic ataxic walk. This is the one everyone fears, and it means you have to act now. And really, this quote just says it all. The definitive treatment, the only thing that truly matters, is immediate descent. Get them down the mountain. Period. And here's the kicker. You've got to do it while they can still walk. Because once they can't move on their own, getting them out becomes so much harder. And honestly, so much more dangerous for the rescuers, too.
Okay, so now let's switch gears and talk about the lungs' HAPE. The mechanics here are a little different. See, when the lungs sense low oxygen, the blood vessels there start to clamp down. It's a reflex called hypoxic pulmonary vasoconstriction. But in some people, this reaction goes completely haywire. The pressure in their lung arteries skyrockets, and it literally starts forcing fluid out of the blood vessels and into the lungs themselves.
So what are the red flags here? Well, the person is going to be gasping for air. Their heart and breathing rates will be through the roof. When you listen to their lungs, you'll hear crackles. But the most terrifying sign, the one that screams respiratory failure is about to happen, is a pink, frothy sputum. If you see that, you are in a true 5-alarm medical emergency.
All right, so we've talked a lot about what can go wrong. Now let's switch to what we can do about it. Let's talk about the clinician's toolkit, how to manage this, and maybe even more important, how to prevent it from happening in the first place.
Think of this table as your go-to cheat sheet. For basic AMS, we can use things like oxygen, acetazolamide, but look closely at HAC and HAP. See the common thread? Immediate descent. That is the #1 most important treatment. Sure, oxygen helps, and we have other meds we can use, but getting that person to a lower altitude is completely non-negotiable. And for prevention, it's the same story across the board. A slow, gradual ascent is king.
So when you're talking to your patients who are planning a trip, this is what you need to hammer home. #1, go up slowly. The classic rule is climb high, sleep low. Above 3,000 meters, you shouldn't be sleeping more than 500 meters higher each night. That slow pace gives the body a fighting chance to acclimatize, to make more red blood cells, breathe faster, and just get used to the thin air. And for those people who are at super high risk, you can also think about giving them something like acetazolamide beforehand to help kickstart that process.
Okay, for our last section, let's bring all this knowledge back to something you'll deal with all the time: your patients getting on a plane.
Something a lot of people just don't think about is that when you're on a plane, the cabin isn't pressurized to sea level. It's actually more like being at 1,500 to 2,500 meters. Basically, you're on top of a small mountain. Now, for most of us, that's totally fine. But what about your patient with fragile lungs? For them, a cross-country flight is the physiologic equivalent of being teleported to a ski resort, and they never even left their chair.
And these are the patients who really have to worry about. We're talking about people with advanced COPD, pulmonary hypertension, restrictive lung disease, really anyone whose lungs are already struggling. And especially if they've just gotten over an exacerbation, the risk of getting dangerously low on oxygen during a flight is much, much higher.
So the big question is, how do you know who's going to be okay and who needs help? How can you screen for this? Well, it turns out it can be as simple as looking at one single number.
And here it is. The guideline is incredibly simple. If your patient is just sitting in your office at sea level and their oxygen saturation is less than 92% on room air, they are almost guaranteed to need supplemental oxygen on that flight. It's such a simple test, right? But it has massive implications for keeping them safe in the air.
Okay, so to bring this all home, I want to leave you with one last question. I really want this to stick. When it all hits the fan, when you're faced with a patient with severe HACE or HAPE, what is the one single treatment that matters more than anything else you could possibly do? The answer is descent. Get them down. Thanks so much for joining me for this explainer.